So thank you very much. Mohammed, and thank you very much, Andrew, for the invite. I would like to congratulate a new vision for the interesting webinar and all this to highlight all the different kind of application of the amniotic membrane. I think it's a very good tool that everyone should use it. So I will, as you can see from my title of my talk, I will explain the use of amniotic membrane in corneal perforation. The corneal perforation mainly results from various disorders, can be inflammatory from infection, inflammation, trauma, or stromal melting. And the management is dependent from size, location, and etiology. Normally we tend to manage with the corneal glue or amniotic membrane transplant with the fresh amniotic membrane, or with the penetrating keratoplasty or tectonic graft. But tonight I would like to highlight that the use of a dry amniotic membrane is a good tool that you can use at a slit lamp, making your life easier and have very good results. So these will show that this slide show that this perforated high cornea is potentially devastating. So can have a persistent leakage that bring a shallow of the anterior chamber with the leakage of the humoracus, and have anterior synechia. You can develop after glaucoma. You can develop cataract after that, and in also endophthalmitis. So this is quite important. So you need to work on this. So you can't leave the patient without it, any treatment, but you need to act. And as quick you act, better it is. And here, again, I'd like to highlight that having this tool on the shelf, like the dry amniotic membrane, help you a lot to act quickly, probably in the best way. So just to highlight which are the patients that you want to know. If you have this kind of patient, the patient have a leakage, but the anterior chamber is stable, or is stable after applying a therapeutic contact lens, that is the patient that does not need a glue. This patient may be helpful to use a contact lens alone, or contact lens plus a dry amniotic membrane that you still have on the shelf. You can shape as you want the amniotic membrane, or you can put a little bit larger, doesn't matter. The matter is that you put a bandage contact lens, and the better if with the dry amniotic membrane. Instead, if you have a little bit large perforation that where there is an iris, as you can see, that is a plugging, or normally we used to use a lot the glue. As you can see, the technique also in the draw below. As you normally you take with the punch biopsy, take a sterile drape, and then on sterile drape from one side you put chloramphenicol, from the other side you put a drop of glue, and then you apply over the, or let's say over the hole. The question that is a temporary occlusion for a small or medium-sized perforation, but the drawback is to remain for only a limited time. Sometimes can detach before the cicatrization is complete, and have a little bit toxic, so it does not help the healing or reduce the scarring. Instead, I will show you now a video that shared by Sumita Charasia, that is a great surgeon. And as you can see, they use the amniotic membrane, as I said, as a graft. So you can put the stromal side on the perforation, you put a little bit of glue. This one needs to be done, as I said, you need to order the amniotic membrane, and you can do in the theater. As you can see, it's quite difficult. It's not possible to do at slit lamp, requires some skills, and but this is to show that a multi-layer amniotic membrane transplant is beneficial, because and beneficial for the patient. The drawback, there is a contain growth factor, exactly, the amniotic membrane, and help the healing, reduce the inflammation and the scarring. The drawback that you need to go in theater, you put some suture still, and this suture can let's say not help the astigmatism, let's say, of the shape of the cornea. I will show a different technique. So the technique that now we propose, but I think we use in the, I don't know if some other people use that already, but we find it quite useful. There are two ways. We try both, and we share the results after we show some patient that's been just published on Eye Journal. So the first technique is a multi-layer, where you can put your corneal perforation, as you can see in the draw on the top, and then you lie down a dry amniotic membrane of the shape that you like. The first thing that you need to do, you need to remove the epithelium around in order that you have some good way to grip your, let's say, dry amniotic membrane. Then you can shape the other one, and you can apply with the forceps in the, let's say, in the hole to do a multi-layer dry amniotic membrane. Then you put the glue that go a little bit higher, bigger, and then again in another amniotic membrane on the top. This is one technique. The other technique is that if it's smaller, you can apply straight away the glue, and then you use on the top the amniotic membrane. Why the amniotic membrane on the top? In both cases, why? Because sometimes it's easy to detach the glue. It's not smooth, so help you to avoid that is discomfortable, or help to avoid also that is moved too much. In addition to this, in both cases, we use a bandage contact lens. It's quite big diameter, between 20 and 22, and these help. I share with you the results. So this is a patient. You can see the color images on the top, and the patient before the perforation. Then you see the patient after the perforation with the corneal glue, amniotic membrane dry, and the bandage contact lens. And then this is the results later on after the color images. The C one is, I think, after 2 months, and was still holding there. Something that is very unusual for a glue to hold so much anyway. This patient, just to tell you the story, had a perforation that used the glue. The glue didn't hold the first time, and the second time, so this lodged after 3 days. The second time again did not hold, and the third time that I see the patient where we tried to do something different, and then we did something with the amniotic membrane, and worked quite well. I prefer, I need to say, the multi-layer one, and I think it could be more a reason that you can you can give some substance, let's say, to the hole, and then hold also on the top. So in conclusion, the glue create, as I said, a raised irregular surface that can discomfort or dislodge the glue. The dry amniotic membrane is quite adaptable and used to adapt to the contour of the glue. A large bandage contact lens help the stability, and amniotic membrane provide an anti-inflammatory and antimicrobial properties, and it's very good and easy to teach and can be used as a slit lamp. So that is my talk, and I would like again to thank you, Mohammed Al-Alfi, for the moderation, and Andrew for the invite. Thank you again.